Hello, I'm Dr. Ken Landa. Thanks for watching. Let's talk about Orilissa. Orilissa, or Elagolix, is a drug approved in July of 2018 as a treatment for endometriosis. It's a pill that you take once a day, 150 milligrams for 24 months, 2 years, or you can take 200 milligrams twice a day for up to 6 months. There's no good guidance which dose is most appropriate for any individual woman. However, what we can say is take the least effective dose for the symptoms that you have and the goals of the therapy. Typically, that means that a woman is going to take 150 milligrams to start, but a higher dose, the 200 milligram twice a day, for those women who have deep dyspareunia, pain during sex, pain deep inside during sexual relations, as opposed to pain at the entrance to the vagina. In any event, women who have moderate liver disease should not take more than 150 milligrams of the medication. You take it at the same time every day. You can take it with or without food. If you take it with a fatty meal, it's going to decrease the maximum concentration in the system by about 25%. And it hasn't been studied in women who are less than age 18, not for women who are pregnant, not for women who have severe liver disease. It's inappropriate to take it with Lopid or with cyclosporin. There's a problem because it can change menstrual patterns, and as a result, it can make pregnancy more difficult to detect. So as a result, a pregnancy test is required before therapy and every month while on therapy. And the Orilissa can interfere with the effectiveness of estrogen-containing birth control pills, and by the same token, estrogen-containing birth control pills can interfere with the effectiveness of the Orilissa. If a woman is going to take the drug, then she should use at least two non-hormonal methods of contraception during the time of therapy, continuing for a week after therapy. The idea about the progestin contraception, we just don't know whether it's going to be effective or not. There is potential for pregnancy loss in women who become pregnant while on therapy. One report showed as many as 49 women became pregnant while receiving the drug. Some of those women had spontaneous abortions or delivered children who had cleft palate or an opening between the esophagus and the trachea. There's no information on breastfeeding. There is some information that the drug may increase the problem with mood disorders that may lead to suicidal ideation. So worsening of depression, worsening of anxiety. One woman committed suicide while on low-dose therapy, just after a month of therapy. Cause and effect we really can't say. May interact with the liver and cause an abnormality of liver enzymes in the blood. Additionally, the common symptom is hot flash. Hot flash is very common. 25% of women on the low dose, 50% of women on the high dose. 20% of the women receiving the medication going to suffer from headaches, about the same number from nausea. About 1 woman in 12 complains of sleep abnormalities, night sweats and anxiety and mood changes and weight gain and abdominal pain and dizziness all may result, and so too may amenorrhea, lack of a period. Well, lack of periods occurs in about 1 in 6 women on low dose, up to 1 in 2 women on the high dose. However, the periods will recommence 3 months after the therapy. Now, the competitive drugs in the same sort of family are Lupron and Synarel. Both of those are stronger and reduce the estrogen level to lower levels and seem to be associated with greater pain relief. There's a problem with any of these medicines, and what they do is they can tend to erase the bone, get rid of the bone mineral density, cause softer bones. So if we look at people who are taking the medicine, let's say for 6 months, and we look at the lumbar spine, the bone mineral density of the lumbar spine is going to be reduced by about 1% in the low dose and about 3% in the high dose. That's a massive reduction in bone mineral density. And it does the same thing in the hip and same thing in the femur. And if we look at 12 months, it's even worse. Does any of the bone reappear after therapy is over? Yeah, it sure seems to. And it seems to be a substantial amount, but it's not complete. And we don't know what that's done to the architecture of the bone. Additionally, taking the medicine might be associated with a small elevation in cholesterol, but it could be as much as 100 points. The triglycerides, again, typically a small elevation, but might be quite significant. And we can't detect some abnormalities of the drug metabolizing enzymes, and they might push the amount of the Orilissa in the system up by as much as 80%, and we don't know it. And we don't know how safe that is. But we do know that it might interact, as I said, with the lopid or with the cyclosporin, but also could interfere with or interact with Crestor or rifampin, or one of those drugs used to make people go to sleep while they receive endoscopic procedures. If you have kidney disease, there's not an issue, but liver disease, if it's mild, it's okay to take the medicine. If it's moderate liver disease, 150 milligrams, but only for 6 months. If it's severe liver disease, you can't take it because the drug is metabolized in the liver. 90% goes out in the feces after it passes by the liver. The half-life of the drug is about 4 to 6 hours. The way the drug works is it sits in the pituitary and prevents a chemical that's made in the hypothalamus from activating the pituitary. When the pituitary can't be fully activated, it doesn't make the signals that go to the ovary that tell the ovary to make the estrogen and the progesterone. That's the way the medicine basically functions. So if we look at how the drug works, it turns down, but it doesn't turn off the estrogen manufactured in the system. So if we look at the ovulation rate, it's about 50% in women who are on the low dose, and it's reduced by about 70% in women who are on the high dose. So still about 30% of the women on the high dose going to ovulate. And that's why the issue of the pregnancy comes in. Well, estrogen is important. The lower the estrogen, the better, at least as far as the endometriosis is concerned, because the endometrial implants require the estrogen in order to continue growing. So studies were done, and the studies looked at women with endometriosis, and it's a very common disease that's thought to affect somewhere between 6 and 10% of women of reproductive age. The symptoms, the traditional symptoms, are pain during the period that's worse than normal, non-menstrual pelvic pain, and the deep dyspareunia. Then pain at the time of ovulation, sometimes pain urinating, pain with bowel movements, a variety of other kind of symptoms. So the study was done by AbbVie, the drug manufacturer. They funded the study, they designed the study, they analyzed the data, they assisted in conducting everything. Actually, some of the authors on the paper were employees of the company, and the ones that weren't were receiving stipends or other kind of financial incentives from the company. So you always have to be a little bit concerned about how much you can believe some of drug company studies. You always would like to see the National Institutes of Health or some independent group perform the study. So in this particular study, the one that was presented in the New England Journal of Medicine in 2017, the article actually had 12 pages of material, 13 if you include the references, but had 72 pages of conflict of interest or potential conflict of interest forms. So the study was done in multiple sites, multiple countries. They only looked at those women who were most likely going to respond. Women who weren't likely to respond were excluded from the study. So women with ovarian cysts or fibroids or fibromyalgia or chronic headaches or low back pain, women who had failed other kind of therapies, excluded. You had to have normal blood chemistry, you had to have normal electrocardiograms, all of those things had to be normal. How the drug's going to work in the real world, we don't know because of the study. We just know how this particular group of otherwise healthy women responded. So they looked at three things. They looked at dysmenorrhea, they looked at the non-menstrual pelvic pain, they looked at the dyspareunia, and they performed their ratings. And what they found was that in the women, if we look at dysmenorrhea, the pain during the period, in the low-dose therapy, about half of the women met their criteria for responding. They responded and they didn't increase the number of pain pills that they had to take. And these women were taking a fair number of pain pills at the onset of the study. In the women receiving the high dose, 76% improved or responded. Women receiving a placebo, well, about 20% of them responded. So there's no question that in the women who have pain during their menses, Orilissa seems to work, and it works better at the high dose than the low dose, and it works better than in the placebo. On the other hand, if we look at the non-menstrual pelvic pain, there was a response in 50% of the women about in the low dose and the high dose, and about 40% of the women, 35-40% of the women, receiving the placebo. Well, if we look specifically at the improvement in dyspareunia, there was a statistically significant benefit, but it was 0.3 points better in the placebo, 0.4 points lower in the low dose, 0.5 points lower in the high dose, and that's awfully closely bunched together. So that doesn't seem like it's very clinically impressive. If we look at the number of pain pills that the women were taking, the average at the baseline was 13 to 15. After 3 months of therapy, women in the low dose were taking 11 pain pills a day, women in the high dose taking 7 pain pills a day, women in the placebo group taking 10 pain pills a day. And even though these women were on a study and they were receiving extra special care, unlike what you would receive in the regular world, still in this relatively small study, 8 pregnancies occurred in the women receiving the therapy. Now, 3 women gave birth to live babies without any congenital abnormalities. 1 had a spontaneous abortion, 2 had terminations of their pregnancy, and 2 were lost to follow-up. So you have to remember that this drug is a treatment for, not a cure of, endometriosis. So you can buy some time, but at the end of the therapy, then the question is what to do, because once the therapy is ended, then the symptoms are still going to occur. Well, is it appropriate to consider longer-term therapy? Well, that's not worked out because of what we talked about as far as the bones are concerned. And as a matter of fact, at the end of the study, women were offered another 6 months of therapy, 6 months of free therapy and all of the laboratory and everything else that was included, no expenses. And half of the women said, no, thank you, off of this drug. Well, there's something called the ICER, and that stands for the Institute for Clinical Economic Review. That's an independent nonprofit agency that looks at medical evidence. They don't take any funding from health insurers or from pharmacy benefit managers or any life science companies. And they issued an alert in August of 2018, and they said, hey, this drug is only cost-effective if we compare it to taking no therapy at all. The cost for a year of therapy is going to be well in excess of $10,000, and there's not sufficient evidence to judge the value of the drug, judge the merits compared to other kinds of therapies. We don't know the long-term side effects. They say it's reasonable for the payers, the insurance companies, to require pre-authorization before women get the drug and to list criteria that women have to be treated with, the different kinds of therapies, prior to getting this kind of a drug. And it requires clinical attestation by the doctor saying, yes, indeed, the patient's getting better in order for continued therapy. And right now, at the present time, it doesn't appear that we have good enough evidence to say that this should be first-line therapy from either a safety or an efficacy point or a tolerability point or a cost-effective standpoint. Yeah, it's a new drug, but it doesn't seem to be anything special. Now, it does work more quickly than the Lupron and the Cineral. That's legitimate. It works about 10 to 14 days more quickly than the other standard therapies. But that doesn't make any difference if the treatment is begun during the luteal phase, right after the ovulation. That negates any of the special benefit, at least as far as the early onset of activity is concerned. And if we look overall at these drugs, we find that still the first choice for endometriosis is non-steroidal anti-inflammatory drugs or progestin-containing contraceptives. And the second-line drugs are still the Lupron or the Cineral or Orilissa probably is in that batch, or maybe even off-label aromatase inhibitors have been used. Aromatase inhibitors, very common for prevention of recurrent breast cancer. They have FDA indication for that, but not for treatment of women with endometriosis. And one has to remember that the treatment is just that. It's a treatment. It is not getting rid of the disease. So when you stop the therapy, the disease recurs. As a matter of fact, they did have one study where they compared the Orilissa to Depo-Provera injections. And what they found was that there wasn't any difference. They seemed to have an equal response to therapy and an equal response as far as the bone mineral density is concerned. Now, the drug company is planning on this to be a multi-billion-dollar seller. And they might be trying to get it from a relatively few patients because the 1 month cost of therapy, the cash cost, is slightly in excess of $1,000. And if you have a coupon, say from GoodRx, it's still going to be around $900. So is this a breakthrough in the treatment of endometriosis? No, it sure isn't. Is it a cure? Nope, not even that. It offers a temporary benefit, and it's associated with significant side effects. Remember, it acts like an eraser on the bones, and we don't know what that means in the long term, but we do know a significant number of women who are postmenopausal are already going to be suffering from osteoporosis, and what the role is of this drug in potentially making that number even worse, just don't know. Anyway, thanks for watching. I'm Dr. Ken Landau.